hope that you all can benefit and bring results to our Malaysian statistics, because we know that some of the London teams, their result is extremely good in terms of maternity service. For example, in St. George's, the maternity death, out of 100,000 live births, they have 8 compared to Malaysia, 27. So our maternity mortality rate is 3 or 4 times more, and it has been there for the last 8 years without improvement. It was improving very rapidly, and then sort of remain static. So I want to over the 45 years in ONG, in the district like y'all, in University Hospital, in Kuching Hospital, in Seremban Hospital, and even Singapore Hospital. I've been there. So over the years, I have seen what is happening and why certain hospitals like St. George's are having better results in terms of complications, pediatric complications, baby complications, maternal complications. So I have more or less summarized the journey that I've gone through, the pitfalls I went in, the landmines that I have stepped on, and all this I'm going to inform you so that you will not drop into the landmine, into the pothole. It is a journey which you are going. It is like driving a car without the headlights on, and nobody's telling you that there's a pothole along the way. So I'm going to point out some of the potholes, some of the landmines which I've stepped on, and it has exploded, and it has hurt the obstetrician. It has hurt the obstetricians mentally, especially, and I can see that senior doctors as well as junior doctors has fallen into the landmine, into the pothole, and badly injured mentally. And so from the summary of what I see, I will try to point out where are the potholes so that you will not go inside. So I call it landmines in obstetrics, and I have been in those potholes along the way in 45 years. I've seen and read the complications of my colleagues, and I'm trying to point out and try that you will not go into those holes. Thank you. Our result is, as I said, maternity mortality ratio. Number of deaths is 27 every year out of 100,000 live births. So this is dealing with mother who give birth. And we have also mothers who expire or pass away because of ectopic pregnancy. This figure is not inside this. So we are talking about maternity service for pregnant women who give birth. That's from ectopic, and septic abortion is not inside here. So if you add those, you will find that then you realize that the figure is about 40. It's around 40. So I'm an alumni from UK, from MRCPG and FRCOG from UK, and I work in Singapore as well, and graduated from there. So I have some idea what they're doing. Their results are as good as London, so that's why I want to share what is the secret people in London, St. George's, and people in Singapore has that we might want to learn so that we can share the secret. If you look at the maternity death, you find that Malaysia is slightly better. We have 29. Malaysia is slightly better than Sri Lanka, China, Thailand. And it's almost the same as Fuji, Brunei. But if you look at some of the countries like Laos, Pakistan, Cambodia, Bangladesh, it is probably 10 times more than our maternity death. This is just the maternity death. So you can roughly see that in Asia, that is up there, we are better than the average Asian result in terms of maternal death. Some of the other countries, Indonesia, India, Burma, Nepal, is quite high. Is quite high. Oh, yeah. So this is Asia, and we are average below Asia. We are 29. St. George's is somewhere here, so it's very low. Probably Australia and London are about the same here, you know. So we want to know the secret. That's why they're here. Malaysia is there. We are not as good as Fuji and Brunei, but we are better than Thailand and China. This is the death rate over the last, from 1933. If you see that the number of deaths is 1,000 out of 100,000 live births. That is 1% in 1933. This is the Malaysia result. And if you follow, you find that over the years, it has gone down to 200 out of 100,000 live births. 100,000 live births. And then it's going down, but over the last few years, it's remained the same. So there is a secret why it doesn't want to go down. We actually want the figure to go down according to the red line. It should go down 2015 to 11. It hasn't. So that's why we need to learn from people like I said, London or Australia, why our figure is not going down. And I'm sure that this kind of calls from those people who have good results to come and teach us. And that's why I think it will benefit. To bring down a figure which we put in on the dotted line, we want it to go down. The maternal death should go down to 11. Okay, you are obstetrician, you are in the clinic, then the patient comes in, and of course you do the pregnancy test and take the biopsy, everything else. So one thing that is important, because you all have a scanner, you all actually want to find out how big is the baby, how old is the baby. So you have some scans around, but the scan at 11 weeks is the most accurate scan regarding the age of the baby. When the baby gets bigger and bigger, the figures change. So at 11 weeks, you can see that it is 4.1 centimeters. And at 10 weeks, it is 3.1 and it's 5.4. So there's a big spread between these 10, 11, 12. So if you have a measurement around 11, you will be quite accurate. How big is the baby? You cannot make a mistake because your measurement is 4.1, 4.2, a little bit different. So you'll be quite sure that somewhere here, because there's so much difference. It's 1 centimeter difference. So 11 weeks, if you measure the crown arm length from head to bottom, you will be able to know how old is the baby, because then you will be able to calculate whether the woman is premature or post-mature and so on, you know. Of course, you can use your last period and so on. You need a calculator. So 11 weeks, you put the calculator, today 11 weeks, then at 40 weeks, that is the expected delivery rate. 40 weeks, that is the expected rate. So that measurement you want to know, on top of blood pressure, urine, weight, and so on. And of course, you want to know the urine, because urine should not be with protein, should not have protein. So you want to know that. So this is the one. Then the other one, I want to know this chart, I want you to know is that the baby during the last 3 weeks grows by 200 grams. At 40 weeks, average 3.4, 3.2, 3.0, 2.8. So this baby is growing at the last few weeks 200 grams. So if the baby is born at 38 and the baby is born at 40, it's 400 grams difference. That's why a baby that goes into labor at 38 weeks comes out easier than a baby at 40 weeks. And if the baby is 41 weeks, it just grows by another 150 grams. So you remember that your baby grows 200 grams per week during the last 1 month. Of course, this is the current language I want you to record in order that you can exactly know when is the last period. You want to have a picture of this or record. When the baby is for 11 weeks, it should be around 42. So if it is 3.1, you know that baby is not 11 weeks, baby is 10 weeks. So that measurement is important to know if the woman is premature or not. Prematurity means 37 weeks and below. Anything above 37 weeks is mature. So you want to do the blood test. These are the normal tests everybody does. So you want to do this test. When do you want to do it? Because the women come early, 5 weeks, 6 weeks, urine test positive by 5 weeks. And then you do this test, which everybody does. And the time to do it is actually 12 weeks. The reason is, I've done it at 8 weeks. And you know that 20% of women have a miscarriage. So after you take the blood, she has a miscarriage. And then she said, look, your blood taking is caused my baby from her. So you cannot explain. So you wait for the baby to be 12 weeks, quite solid, and then you do the blood test. If you've done the test too early, then a lot of them will blame your blood test and say that because you take the blood, I have a miscarriage. So I have done the test at 6 weeks, and 20% of women miscarriage. Not everybody is going to have a baby. So when they are pregnant, 20% will have a miscarriage. If they are more older, 30%. So you are worried that if you take the blood too early, they'll blame you later on, they have a miscarriage. So you do it at 12 weeks, okay? Inside this test, the most important test is actually a blood group and rhesus factor. That is the most important. The patient comes and delivers with you without any record, and the patient is bleeding, and you find that there is no record, there is no blood group. Now, how are you going to do? What blood are you going to give the patient? The patient is bleeding. That is why you must know the blood group immediately as soon as possible. You know that in the army, the soldiers, they have a blood group written in the card, in the metal tag, so that when they are down, bleeding, the army doctor will give them the blood group. If the patient is A+, the army doctor immediately will give A+ to save him. That's why in the army, they have to carry their blood group inside the card they wear on the shoulder. Same thing, a woman must have the blood group inside the card so that you know. And I always tell the patient, you must know your blood group. During emergency, you are fainted, the doctor doesn't know what blood to give you. And so you might, get your difficulty. You must tell the patient the blood group, maybe the husband. And of course, here the blood is 99.9% positive, research positive. And very, very few are negative. Other countries, up to 10% have the research negative. So we are not too worried because if the patient is A, they will receive A. If the patient is B, they will receive B. If the patient is AB, they receive AB. So that is the life-saving procedure that you must have in mind during emergency. Because a lot of women just come and bleed inside your hospital, and you're looking for the blood bank officer to do the blood group. Then he's not around. And then he's not answering his phone. It's a weekend. And then what do you do? So you must be able to know the blood group. And of course, if the patient is A, give A. Patient is B, give B. Even without the group endorsement. Because normally the group endorsement is no problem. It's compatible all the time if it's the same blood group. So that's so important. The rest of it, you actually not that important. But if the patient has hepatitis antibody, then you do not want to vaccinate after delivery. If the patient is a carrier, then you want to record down because the baby will be immunized differently, starting differently. And HIV, there are patients, some of them have HIV. And rubella, you have to give immunization if there's no antibody. So blood group is the most important. I put there very big. It's a life-saving knowledge that group during emergency. Without that, you have to look for O negative or O positive. But a lot of patients pass away postpartum hemorrhage without the blood being given. And then they always say that I should have given the blood. But the lab technician is not around. So I didn't know what blood group did we give him. So you should actually just give O in the emergency. This is important. You must know the blood group. Write it down in the card. Of course, universally, most people are O, fortunately, because O is a universal donor. You can get a lot of O blood to give to everybody during emergency. But ideally, it should be the same blood that you give to your patient. If the patient A, you give A during emergency, B, you give B, and so on. O, you give O. But real emergency, O negative would be ideal, but Asian country, the negative rate is very low. You just give O positive. Because 99.9% here are research positive. You don't worry about it. So that is how they give the blood. And A, you give A, B, you give B, emergency. And what type of blood you want to give? You want to give PEG cells, because blood contains half of it is plasma, serum plasma. The other half is red blood cell. So during emergency, you want the PEG cell, because one PEG cell is equal to 2 pegs of blood, because you remove the plasma. You really want to give the red blood cells, and you don't want the plasma, because plasma has antibodies which might cause reaction with the patient. So you do not want the plasma. You give PEG cells during emergency. And of course, you check the patient's hemoglobin antenatally at about 12 weeks, and you find that patient's anemic, and 99% is iron deficiency anemia. So you treat the patient along the way, because during delivery you want the patient hemoglobin to be up. So you want to treat that along the way. I always give them 2 or 3 tablets from 3, 4, 5 months, and finally they from a pale patient they recover in 2 months to a pink patient. And so you just give iron tablets. And then if you are looking for preeclampsia. So preeclampsia, you want to find out whether the protein is in the urine, albumin. Because normal pregnant woman should have no albumin. So you're looking for albumin, because the moment you find albumin, you are talking about preeclampsia. Albumin can be 1+, 2+, 3+, 4+. The more plus, the more dangerous is for the baby. And of course, swelling, edema, everybody has. So it's not so important. I put it down at the bottom. Every pregnant woman seems to have a bit of swelling in the legs. So the BP should be normal, and it should not be high. So if you have high BP, albumin, you have to be worried. You'll be worried because you have preeclampsia. Preeclampsia, the patient usually is the firstborn primary gravida, although it can happen in multi-gravida. In preeclampsia, you do not want to make the blood pressure normal. The body is trying to pump blood into the placenta through to the baby. Somehow the body raises the blood pressure so that there's enough perfusion to the baby. If you lower the blood pressure to normal, the blood supply actually goes down. So the body actually wants to increase the blood flow to the baby. So if you make it too low, you actually harm the baby, because the blood supply is now getting less. And most important in preeclampsia is rest. You must rest the patient. She is usually a primary gravida who is doing a lot of work. And if you continue work, then the blood pressure gets higher and higher. And then the protein will continue to be 2+, 3+, 4+. And then the blood supply to the placenta, to the baby, will become less and less. And you get a stupor, fetal death in preeclampsia. So a lot of people forget the most important treatment is rest. No more work, rest at home or rest in the hospital. That will bring down the blood pressure. And of course, you have other drugs as well. But don't be too aggressive to make the blood pressure all the way down. That actually harms the baby. And you have some drugs which we always use for preeclampsia. Sometimes we use one, beta-dopa, sometimes we use levodopa, Candid. So sometimes a combination of both together with rest and frequent checkup. And of course, the women will come and say, "Doctor, I want you to deliver, and I want certain conditions." So the patient will say that, "I want a normal delivery, vaginal delivery." You know that you cannot promise that, because if there's fetal distress, if there's prolonged labor, you have to do cesarean. So you do not play to the patient's request. You have to warn the patient that if there's fetal distress, if there's prolonged labor, I have to do cesarean for you. There are many cases, the doctor said you must do cesarean because fetal distress, the mother-in-law said no, wait for another hour. And the father-in-law refused to sign and so on. And in the end, fetal death after birth. They will bring the lawyer and sue you. And then you look at the record, I've written there 10 times, asked you to do cesarean, you refuse. So they are causing trouble to you because they want a vaginal delivery. Somebody has told them, must be a vaginal delivery. Never promise that because they're going to sue you anyway. Whether you have normal delivery, if something goes wrong, they're going to sue you. They'll bring the lawyer. So never promise that. And then they'll request for a lot of other things. But one thing is, we don't want to promise. Because if they say, I want you to do a normal delivery only, then say, sorry, I can't do that. Because if there's complication, I have to do cesarean for you. That part you must impress on the patient, that they cannot control the management when they come to see you. Otherwise, you get a complication, they'll sue you. So don't play around with the patient request too much. Certain things you have impressed from the very beginning when they come and see you. If you have complications, fetal distress, meconium stain, I will do a cesarean for you as soon as possible. And a lot of patients, they have labor, lingering labor, I call it. That means it's neither here nor there. A bit of pain, admit to hospital, go in, go out, go in, go out. And then in the end, because there's no monitoring, the fetal death happens. So do not allow lingering labor. Neither here, nor there, not sure. You know, also 1 cm, she's not sure. Sometimes have contraction, sometimes don't have. We don't allow lingering labor. We must be active in our management. So there are 2 types of cesareans. One of the cesarean you do early. The other one is cesarean after you fail everything else. This is the cesarean that a lot of doctors adopt. That means cannot deliver, failed vacuum, long labor, more than 12 hours, maternal distress, fetal distress. Then you do Caesar. That Caesar is actually more risky, more difficult, because the baby's head has gone in right at the bottom, and it's neither here nor there. When you do cesarean, you're supposed to see the head, but actually you see the shoulder. Now, how are you going to deliver the baby halfway in, halfway out? That kind of Caesar is very difficult. It causes more bleeding because you have to put your hand in to the vagina and pull the head up. In doing so, the tear happens along the vaginal wall, and you have bleeding during cesarean. So that is a late cesarean, which you do not want to get into. You have no choice sometimes because patients can come and see you. The head is neither here nor there. You know, you can feel the head there, but then you have to do cesarean, and then it's a risky cesarean with more tear because the head is too far down. So obstetricians have a lot of stress. If you have tears in the 3rd-degree tear, you have hematoma formation at the bottom, at the perineum, and then you have lawsuits. Patients are happy for some reason, maybe the baby goes to ICU. a patient complains that it's painful, and so on and so on. And then fetal complications, the baby's not well, sent to ICU, they will complain. So that increases your stress. You expect everything to be straightforward, happy, but then you have stress. So if you have a lot of these things, then you realize that will affect you mentally as an obstetrician. So patient will say, I want to deliver at home. I want to deliver underwater because somebody says it's very nice to deliver underwater. Don't agree to that. Because there have been cases, the baby is born in the bathtub and drowned, full of water in the lungs. Don't allow that to happen because they said somebody has done it, Don't allow home delivery in our setting because in this place, when they deliver at home, it's 3 hours to the hospital. 2 years ago, there was a teacher in Kuala Lumpur. She delivered at home. And of course, tear and bleeding. 6 p.m. traffic jam, the ambulance came 3 hours late. She died at home. So, some of these patients, they read a lot. And they say that some people have delivered at home, some maybe on the time. Don't allow that. If they want, tell them don't do it. Because you need, if you are bleeding postpartum, you need to go to hospital, have a blood transfusion, which you can't. So when you're checking the women every month, in the beginning it's every month, right? Every month, you will be looking out for some of the good signs to see how risky this patient is. If at the time of last month, the baby's head is down, it's good. Because this breech is not good, right? So the last month you want to worry, the head is down or not? And is the patient more than 37 weeks? Because if the patient gets to level below 37, it's premature. Sometimes they get to level 32 weeks. So you might want to give dexamethasone, 12 milligrams, 12 early, in anticipation that this patient might deliver too early. You want to mature the lungs. So you want to be able to give dexamethasone, 12 milligrams, 12 early, so that the lungs can mature in case you deliver early. You want to identify those. Particularly if they tell you every delivery is 32 weeks. So now he said, I'm going to give you dexamethasone because you're going to deliver 32 weeks. I want to give you dexamethasone 28, and it lasts for 2 weeks. So 28 you give, she didn't deliver, 2 weeks later give again, two doses, and so the baby's lung is mature. When she suddenly delivers, the baby has a better outcome. So you are prepared. And if you see that this patient is multi-gravida, you're happy, because primary gravida has more complication than multi-gravida. Multi-gravida means that she has successfully delivered. So that is a good point. So you like this kind of patient. These kind of patients, they probably get a short labor and they deliver. Now, what are the cases that cause trouble? Okay, breech. You are not going to deliver a breech because the head gets stuck, the neck gets extended, and whatever you pull, you cannot get it out. There are many ways to do it, but I would say don't try it because you will not be in time. When the baby head come out, you are not around, and the baby is hanging there, they will sue you. So, some of the difficult cases, twins, be careful, because you might get the first one out, the second one is stuck, breech, or can't come out. Then you do scissor for the second twin, it doesn't make sense. Might as well do scissor. If the woman has previous cesarean, that means she has failed to deliver once before, for some reason. If it is placenta previa, maybe this time she can deliver. But be very careful of this. If she cannot deliver once, it's not likely she's going to deliver second round. She might deliver, yeah. But do you want to take the risk because of rupture, because of prolonged labor? She has already proved to you that she can't deliver vaginally. So with that in mind, you have to be careful. You might want to do an early Caesar. There are some people who try to deliver and then manage to get good result, but there are many cases they have bad result and they would tell you. So you think that previous Caesar you can go for another Caesar. Maybe you are going to be mistaken. You become caught in this argument. Those difficult cases they will not tell you. Those they have done Caesars, they'll tell you and publish it. So if you look at the result, a lot of people have done it. But if I were obstetrician, I would rather not take the risk because I'm taking more risk than what I am expected to. I would rather do an elective Caesar and be happy about it. Elderly by me, the more elderly, the more problem. Somehow the cervix doesn't open and the labor gets long and in the end, never deliver. So elderly primary, be careful. Cord round neck, many times delivered normally because the cord is long. But many times, if you scan, you see the cord round the neck 3 or 4 times or 2 times. Those, I would prefer the Caesar. I would prefer the Caesar. Because so many times, we let them deliver the fetal distress, and then you do a Caesar. So sometimes, if I see cord round neck twice, I would just say, let you go for Caesar. Because when the cord goes around the neck twice, it becomes too short. And when the baby tries to get out, it strangulates the baby, the blood supply drops, fetal tachycardia, distress, and so on. So, cord round neck 2 times, I'll do Caesar. Preeclampsia, the more BP, the more mature, I'll do Caesar. If it's not premature, we just rest and treat until time comes, I will do Caesar. So there are certain areas that you don't want to get into. And the escape is to go for elective Caesar. As I said, early Caesar is 3 times easier than late Caesar. Don't want to go into late Caesar. The onset of labor. See, a lot of women come, you don't know when she's in labor, when is it, and then, so you don't know when is the starting of labor. And that is a big problem, because if you want to measure long labor, you must know when you start. It's like an aeroplane taking off in the runway. The aeroplane has to start from this line, and you must take off at the end of the runway. There is a beginning, there's an end to the whole thing. You cannot just let the aeroplane go down there, you cannot take off, come back, start again, go round and round. That is what happens in a lot of cases. Something goes wrong because you do not have a chart to show beginning and end. That's why we need active management of labor. That means you start knowing when you start labor. So for me, patient is in labor, 38 weeks, 37 weeks, she's in labor, I will rupture the membranes. Immediately, I will put up a drip with 10 units of syndestrone. So this is my mark. This is the beginning of labor, and I have a chart called a partogram. I want to know that from this point towards the end, after 12 hours, can she deliver? But if you don't have a mark there, then you don't know when she deliver. Maybe is it last night? You know, you want to start the partogram from the beginning. So you rupture the membranes. Why? Because there are women in labor, the membranes rupture inside. It's not rupture at the bottom. Automatically, by itself, rupture inside. And the fluid gets into the circulation. And she got amniotic fluid embolism. She gets into shock. She gets into pallor. She gets into difficulty breathing. So you do not want the membranes to rupture inside, in the uterus, up in the fundus. So that's why you want to drain out the liquor. There is a good reason why you want to drain out the liquor early part, maybe 1 or 2 cm. You drain out the liquor. So there is no way the embolism can occur during labor. I've seen myself, a patient in labor, 5 cm, suddenly it fainted and embolism. Because the rupture membrane is inside by itself and it gets absorbed into the circulation. So to prevent amniotic fluid embolism, you want to rupture during labor early so that there's no liquor to be absorbed. You want to have vaginal delivery You want to have a beginning part, you want to LMP the rupture membranes and the drip, so that you know where you are in the beginning, and then by 10 or 12 hours, you should have a delivery. You should have a delivery, either vaginal or cesarean. Along the way, a lot of them will deliver. Along the way, because you have a drip, you have good contraction, and the worst is that the patient has no contraction, and maybe don't know when it starts, when it ends, and nobody knows she's in labor. Actually, she's in labor since yesterday. So now the labor is 24 hours now. You actually have a prolonged labor without knowing it. She's having labor a little bit, nothing happening. It goes on, and because you did not pay attention, she's actually in prolonged labor. There is fetal distress, there is fetal tachycardia, which you don't realize. And of course, the baby come up blue because of the prolonged labor. Then, if you come towards the end of 12 hours, after active management in labor, then you can go beyond that, right? Then the problem happens. You got prolonged labor, you got fetus might get 170, and CTG normally is 130 to 150. And the normal CTG is like jagged. They call it, there is a big to big variation. That means it goes up and down, like it's like a saw. It's not smooth. So when the CTG goes to 160 and it is smooth, then you better worry, because it's fetal tachycardia and loss of big to big variation. That means it becomes smooth. It is a little bit only. It should be like this, up and down. So then you get prolonged labor. The longer you wait, the more the head goes in. And now you're going to have a difficult Caesar because the head is inside there. And sometimes it is neither here nor there. You try to vacuum, you fail, then you do Caesar, right? So you all have come across this sort of thing. It gets longer and longer, the problems start happening. And of course, if the uterus keep on contracting for too long, even normal delivery, the uterus get tired and cannot contract, then you get PPH. So prolonged labor, uterus gets tired, and then you get PPH because uterus is tired and cannot contract. Because you need the uterus to contract before the bleeding stops. If the uterus doesn't contract, it keeps on bleeding because the blood vessel is coming from outside to the muscle into the cavity. So if there is contract, the blood vessels get stopped. And this is the CTG that you might see after long labor. You find that it is smooth and tachycardia. It goes to 160, 170, 180. A normal one will be 135 to 150 and goes up and down like a seesaw. You're happy with that, you're not happy with that one. Particularly when it's deep, it drops, you're not happy. Because it is fetal tachycardia, and then you go further, you get dips. So dip is following tachycardia. It goes to tachycardia first. If you don't do anything, obstructed labor, then it goes to dips. Then there will be more dips. So the first dip with contraction, it dips. Later on, it dips without contraction. So that is getting worse. Because during contraction, the blood supply gets less into the uterus. So of course, remember that after the baby is born, everybody forget. Everybody's so happy. Everybody forget to give the symptometrin, like crowning. They have shown many years already. If you give symptometrin or syntocinon IV 10 units, you realize that the PPH is less. So you want the uterus to contract as fast as possible after delivery. That's why crowning, inject symptometrin. A lot of people forget. Everybody's so happy. The midwife forget. The father is not going to drink the wife, and you forget to give the symptometrin, and the uterus remain relaxed. And then you must wait 10 minutes, 5 to 10 minutes for the drug to work. You give IM symptometrin, the uterus will slowly contract and expel the placenta. So what happens if you give the symptometrin and then the uterus has not contracted? it takes time. Then you pull out the placenta. It will be massive bleeding because the uterus is still relaxed. So this is one area you must wait. Wait for the drug to work first. Don't pull up the placenta too early before the uterus contracts. In fact, when the uterus contracts, the placenta drops out by itself. You don't have to pull it. The placenta is sitting in the uterus. The uterus contracts, it cannot hold on. It has to come down, drop out. It's like a jellyfish sitting on the roof. If the roof keeps on contracting, the jellyfish drop down. His footing is lost. So you must wait. A lot of people forget. And then say, why? Every time I deliver, I get a PPH, poor bleeding. Somebody forgot to give the cytometrin, which actually consists of cytosinon and ergometrin. Both of them have to contract the uterus. If you have a drip, sometimes you give IV cytosinon. Is IV cytosinon, which contains cytosinon without the ergometrin part. So, if you look at the causes of death, you find that, we have the video. Postpartum hemorrhage is the first one, okay? And then there's a preeclampsia, hypertension, blood vessel burst, and so on. And then amniotic fluid, you can do something about that. You rupture the membranes earlier. And then ectopic pregnancy is also, there's no live birth there, but ectopic pregnancy is very common here because the woman gets pregnant in the raw area. And then she doesn't know she's pregnant. So around 6 to 8 weeks, she has an acute abdomen in the raw area, and she has a stomach ache, and she will bleed, and she will turn pale, and by next morning she's dead. This ectopic pregnancy, because I've seen myself a few cases of my own patients that died from ectopic pregnancy in the longhouse, which is half a day by boat. So if a woman who has early pregnancy gets a stomach ache, urine pregnancy test positive, always remember ectopic pregnancy. Yeah. So what I'm saying is that you want to reduce complication, you want to reduce stress, you want to reduce PPH. Go back. So there is a way to do it. A lot of doctors think that if you do cesareans, you can solve a lot of problems. So that's why a lot of hospitals now are doing more and more cesareans in order to reduce stress, complications, fetal, maternal, PPH, and so on. So if you don't do cesarean, let's say 5%, your stress is very high, complication, and so on is very high. But if you do early cesareans, you find that your stress goes down, complication less, fetal, maternal complications less. So there is an area that you must do enough cesareans in order to prevent complication. So I've done that. But of course, if you keep on doing cesareans, you get into more stress, your staff gets more stress. You know, everybody goes for cesarean, your staff gets more stress. So there is a best result. I see some of the hospitals between 20-30%. So they do not want to deliver the high risk. They do not want to deliver precious baby from IVF. They do not want to deliver twins. They do not want to deliver breech. They do not want to deliver elderly primate, and so on. So that is a good program, that you be more active in order to prevent complications. The other way is, let everybody deliver until complications set in, then you do Caesar. That is not active management level. You want to be active, because early Caesar is much easier than late Caesar. So the head is up and Caesar is easy. So normally before you give the patient blood, you give your patient is normal saline, plasma expander, it's just to buy time. But the saving one is the blood transfusion. You cannot keep on giving volume normal saline for a long time because the blood pressure can maintain only for a few hours unless you give the blood. So this is just temporary measure. Volume is a plasma expander. Normal saline helps to bring out the blood pressure. Really, you got to run for the blood. The other trick I learned over the years is triazamic acid. Triazamic acid has been there for 30, 40 years. And now, more and more people are using it. This prevents the patient from bleeding for some reason. They use it in cardiac surgery, during surgery. They give it pediatric surgery. They give it in the emergency room, accident cases, bleeding cases. And it helps. It really helps the patient to stop bleeding. And the amount of bleeding is much less. So there are some doctors, professors who think that every case of bleeding should be given this one. So I have a stock up triazamic acid. I've used it and I find that it is really good, and it's not only good, it's cheap. And not a lot of people know about this, but if you look into the literature, the surgeons are using it, pediatric surgery, heart surgery, and we use it, tablet to stop heavy period. Triazamic acid tablet is used to stop heavy periods, to stop epistaxis, nosebleed, and there are people who use this for bleed in the brain. There are obstetricians who use it for bleeding during pregnancy inside antepartum hemorrhage, and the result is good, doesn't seem to hurt the baby. So it is underused. In patients with bleeding, you might want to give triazamic acid. During cesarean, you might want to give it. It's very safe, and you should stock up this one. During Caesar, if patient bleed a lot, you give 1 gram, and then you put another 2 grams in the drip and drip it, and it really stops the bleeding like a miracle. The bleeding stops. Yeah. This is one of the measures. Other measures our lecturers will teach you. This is just one way. This is another trick up your sleeve in order that you have more option when you meet with a patient who's bleeding. The other thing I use is to make the uterus contract. You sometimes give a lot of symptometrin and ergometrin. It doesn't want to contract. Now we realize that if you suck the uterus with the tube, which is sealed quite tight on the cervix, you can actually make the uterus contract by sucking it, collapsing the uterus. So quite a lot number of people are using this to contract the uterus. This is the tube that we use, put in the cervix, and if the uterus doesn't want to contract, you seal it and suck it through this end. I find that this is quite good to contract the pressure. Not a lot of people use this, but I've used it many times. If you see the uterus soft and doesn't want to contract, this is one measure. Now, patients going for cesarean, long labor, more than 12 hours, no progress. So you want to go to labor. So now you prepare the patients for labor, right? For cesarean. This is just in the scrub room. I put some alcohol so that when I scrub, I dip my hand in to sterilize. And sometimes you put the patient in the operation room. The patient is turned blue because she's naked and she's cold. Temperature is 16 degrees. And then she turned blue, and everybody is wondering why the patient is turned blue. Actually, the OT is so cold. So think of the patient who is naked in the operation room. You are down now. The patient is naked and she's turning blue and she's shaking. So we should think of the patient's comfort. Don't put the aircon until it's so cold. And of course, after baby is born, sometimes the nursery is so cold and the baby is freezing inside there. Nobody seems to notice, you know. So as we said this morning or this afternoon, temperature is important for baby. Baby should be warm. There's a heater, blankets and so on. So baby must be kept warm all the time, those who look after the baby. Before, for many years, we have patients coming for repeat cesarean with adhesion. I was in Kuching. Every case coming in, repeat seizure, took us more than an hour. Specialists are very scared because it's all stuck. And then we realized that these are patients who have had seizure before using powdered glove. Powdered glove causes adhesion. The powder itself causes adhesion. You know that powder you inject into your pleural cavity to cause adhesion so that your lung doesn't collapse. Talcum powder is adhesion causing substance. If you use powder glove, it's easy, very smooth, easy to operate, but sex scissor is all stuck. So do not use powder gloves. Now it's banned. Powder gloves is banned nowadays. You do not use powder gloves. Use powderless gloves so that the next guy who goes in will not get odor adhesion. So this is something we learned over. It took us a long time to realize this. Why do patients get adhesion? Patients from Bintulu coming to Kuching, all get adhesion. Even in Kuching, we get adhesion because we're using powder gloves for many years. Nowadays, we do not get adhesion because we use powderless gloves for cesarean. You see that this patient is going for spinal, and then we put some zinc oxide cream at the bottom, and there is a good reason why. We have a few seizures done, and the patient, after second, third day, complained of a bluish blister at the back. And then we were wondering what happened. It's not too painful, but there's a blister. I haven't got a photo. It's blister there. And we keep on thinking, what causes the blister at the bottom? Actually, it is due to the iodine. If you put a lot of iodine on the patient, a lot of it goes down to the backside. Then you put alcohol spirit, second layer, it all goes to the backside, and there's a plastic there. So at the patient's bottom, there's a layer of pool, iodine, and spirit. And this causes the blister, and iodine can burn. So you have a little bit of burn at the backside. So when you wipe the patient with iodine, don't pour the excess onto the patient because it's going down to the bottom. So that is the reason why we put something outside. That's a trick. That's a trick you learn. This is a patient going for seizure, and you notice that when you put iodine, I see some patients just put a little bit iodine in the middle of the tummy, and no iodine at the top, and then they get infection because the thread moves down and bring the germs down into the field because the thread is moving. So you should thread the patient, iodine the patient from breast to knee, nipple line to knee, all the way. So that when your towel, sterilized towel move, it doesn't carry the germs below up. You got it? So you must put iodine knee to nipple, okay? And the other trick is you must wait for 1 or 2 minutes. You don't put iodine and then wash it because the germs are still alive for the first minute. So if you just put iodine and put alcohol, you find that you get infection because the skin is still not sterilized. You have to wait for 1 or 2 minutes, and then so that is the time when you must wait 1 or 2 minutes for the iodine to kill germs and also the spirit. There's another solution they use is chlorhexidine. It's a soapy, slippery kind of thing. It's also equally good, more expensive, but the patient is a bit wet and slippery. I don't like it, slippery and wet. Alcohol, second layer, is good because the alcohol evaporates. So when you start doing cesarean, you find that the patient is dry, rather than slippery with soapy solution. Chlorhexidine is soapy, colorless solution. So I like the spirit because I use alcohol. Ethyl alcohol. Some people have used methyl alcohol. It's about the same. Industrial spirit, methyl. Surgical spirit, ethyl. But they all the same. 70% alcohol, 30% water. Reason of 30% water is that it doesn't burn so easily. So some alcohol, second layer, let it dry. That is the other trick you must learn. Let it dry, let the alcohol disappear. Why? You read in the newspapers, cesarean, the patient caught fire. The patient caught fire during cesarean. Because you have used cautery and there's alcohol. So cautery and alcohol, fire, you know? So before you use cautery, make sure the alcohol has evaporated. Otherwise, the spark from the cautery will cause a fire on the tummy of the patient. It happened in New Zealand, came out in the newspapers. And of course, if you do early Caesar, the head is high, then you can use a vacuum to deliver the head without putting your hand into the pelvic cavity and try to pull out the head. Because when you put the hand in, it's going to tear, right? Because the cut in the uterus is that big. Now you put the hand in, and then you pull out the baby's head from inside. That is going to tear. It happens all the time. That is why you do not want to do late cesarean. You try to do early cesarean. The head is already there, and you take out the baby with the vacuum so that you don't have to put your hand in. This can be possible early Caesar, right? Early Caesar you can do it. Now, there are a few tricks when you do cesarean, which I'm going to show you in video. Some of the useful tricks which I learned over the years, which I'm going to show you. Maybe we will show you the video. Oh, I don't have time to show you the video. Okay. You can go to YouTube and look for it. Under the video, standing of my son, they put it. So this is how you get the uterus. But basically, it's like this. If you find that during the cut is bleeding, you want to, at the incision area is bleeding, you want to palpate along below on both sides. And you see the uterine artery that is pulsating underneath it, right? And then you use a FRCOG to catch it and ligate it, pull up the artery. It can be done from uterus inside there, from the anterior part, go in, ligate it. Or behind, you can put out the uterus, and from behind the uterus, you can feel the uterine artery pulsating there. Then you use a FRCOG, catch it and stitch it. So it will stop a lot of bleeding. This is just a trick. You go to YouTube and find how I will do the uterine ligation during cesarean. And remember, after baby is born, you give, during cesarean, you give antibiotics. I like to give ceftriaxone after baby is born. This is using distilled water to dissolve the powder. You don't give IM because IM, Rosifin is a local anesthetic inside there. You don't want to give because the local anesthetic, if you give IM, you get into the circulation and baby might get a fit. So you don't want to give IM because the IM Rosifin, there is a liquid inside. It's not normal saline, it's local anesthetic. And you do not want to give local anesthetic when the baby is inside. You give Rosifin, and then if the baby is inside, then the baby gets a fit from the anesthetic. So you give IV, which you don't use local anesthetic. The sutures, we have been giving micro sutures with a big short needle which is square and fat. And I find that every time I stitch, it bleeds. So I've decided that this square big needle is no good for cesarean. So I go and buy smooth needle which is bigger. A bit bigger. This is 40 mm. You get 48 mm longer needle. I like it. It's smooth, round body, less bleeding. And I have a smaller needle. So we use a smaller needle because if you done scissor, you see every time you stitch, and the needle mark is bleeding. Because needle is too fat and square and too big. Okay. During cesareans, you must have all your gauses laid out on the floor so that you don't have any missing, right? Don't have any missing. And your pad, you must put it up on the floor so that the nurse can count it. The trick about these pads, sometimes children, you lost it. You want to close up and say, sometimes how many pads did we use? It started with 1 or 2, and then during the operation you open another one, and then you forget how many pads we use. So now the trick is you put pads 2 in a bundle, so that every time you take is 2, 4, 6, you know, so that right, it's either 2 or 4 pads for these pads. So all the pads must be 2s, and all the swabs must be 10s. So 2 packets of gauze and 2 pads. 2 pads inside got 4 abdominal pads. So when you use the abdominal pad, there's a tail. During Caesar, the tail must always come out of the wound. Otherwise, you'll miss it and forget. And then, after Caesar, the nurse will call you, patient's BP is 80/40. And then you say, oh, what is happening? But there are 2 scenarios. Patient's BP 80/40, pulse only 60. The other patient, 80/40, pulse 110. So most likely, this is the patient that is bleeding. That patient is heavily sedated with morphine. So the pulse is low. So you have a rough idea, looking at the pulse, whether the patient is bleeding or not. But again, if the patient is bleeding, she will be breathless, tachycardia, sweating, and so on. So this is the trick that you want to learn. Coming back, ectopic pregnancy, a woman who has urine test positive around 7 to 8 weeks with acute abdomen, always remember, it could be ectopic pregnancy, and you need to, again, blood transfusion, right? So basically, we want to get to easy deliveries, and we don't want to mess around with complicated deliveries. So we Caesar what is risky, and we will try to identify what is easy, and with that, you will be able to do your obstetrics with more peace of mind. And oh yeah, I will come to the end of it. So thank you very much for your attention.